Welcome to the Funnel Effect. Today we're jumping into a really complex area of hard medicine. We're going to deep dive into treating patients who have, severe heart failure and complex coronary blockages, but they're considered just too high risk for standard open heart surgery. Specifically, we're looking at high-risk percutaneous coronary intervention, or PCI, that's stenting for these folks with really low heart function, what we call reduced left ventricular ejection fraction, or LVEF. Our main guide for this discussion is a major clinical consensus statement. It was published fairly recently in Eurointervention, the 2025 volume, pages 22 to 34. The title really spells out the focus. High-risk percutaneous coronary intervention in patients with reduced left ventricular ejection fraction deemed not suitable for surgical revascularization. A clinical consensus statement from the European Association of Percutaneous Cardiovascular Interventions, EAPCI, in collaboration with the ESC Working Group on Cardiovascular Surgery. Quite a mouthful, right? And because this represents a huge collaborative effort, a consensus like this, it's really important we acknowledge the authors.
It's a long list, which just shows how many experts weighed in. Those credited with equal contribution are Andreas Schaefer, Mirvat Alesnag, Nikos Werner, and Giuseppe Tarantini. But the full list includes Andreas Schaefer, Mirvat Alesnag, Daniel Jacopo, Carlos Collet, Tanja K. Rudolph, Ariel Rogan, Piotr P. Busman, Rosen Colleran, Julia Stefani, Thierry Lefebvre, Niels Amigam, Guillaume Keila, Christoph Naber, Andreas Bombach, Adam Mudkowski, Francesca Berzata, Davide Capodanno, Darius Dudek, Rasha Alamé, Adrian Banning, Philip McCarthy, Roma Gottardi, Florian F. Schoenhoff, Martin Scherney, Matthias Thielmann, Nikos Werner, and Giuseppe Tarantini, who was the corresponding author, and Franz Josef Neumann served as a guest editor. Phew. Okay, that extensive list really highlights just how multidisciplinary this whole problem is. So our mission today for you listening is to kind of cut through the complexity. We want to give you a clear understanding of this tricky intersection between advanced heart disease surgical risk and these cutting-edge stenting techniques. The big question this consensus tries to answer is when the usual gold standard bypass surgery, CABG, is off the table because it's just too risky. How do doctors safely and effectively use PCI for these very complex, very sick patients? Okay, let's unpack this.
Yeah, and the need for this kind of guidance is really being pushed by, simple demographics. We're facing a huge public health issue. Why? Because the number of people with complex coronary artery disease, CAD, who also have heart failure, or HF, is just climbing fast. A big part of that is simply aging populations. People are living longer, but often with more chronic conditions.
Right, more time to develop these complex problems.
Exactly. And if you just look at heart failure numbers, it's staggering. Something like 1 to 2% of all hospitalizations in Europe and the US are because of HF. Now, narrow that down. Think about patients who not only have HF, but specifically severely reduced left ventricular function, a weak pump, basically, low LVEF and complex anatomy in their coronary arteries. You're dealing with an incredibly fragile group.
So we had this growing group of really sick patients, but the standard guidelines, they seem a bit behind the curve for this specific group. For years, things like the ESC guidelines have pushed CKBG, bypass surgery, as the main way to go for patients with both CAD and low LVEF.
That's absolutely right. And there's solid reasoning behind that recommendation. It comes mainly from older randomized trials, especially the STCH trial. STH showed a real long-term survival benefit with surgery compared to just medical therapy. But, and this is the key point, STH looked at patients who are actually considered low or intermediate risk for surgery.
So the very patients this consensus isn't about.
Precisely. This consensus is for the patients. STCH deliberately excluded the ones deemed too high risk for an operation.
And here's where reality really clashes with those guidelines, isn't it? Even though the guidelines point to surgery, actual clinical practice shows that PCI, the stenting approach, is chosen instead in almost half of these complex cases.
That's the disconnect. It happens because many patients are just too frail. They have too many other serious health problems, making surgery incredibly risky. Or sometimes, after being fully informed, the patient simply chooses not to undergo major open heart surgery.
Which creates this huge gap between the best evidence from trials on healthier patients and the actual clinical need for these sicker ones.
Exactly, and this is where the consensus document really emphasizes the role of the multidisciplinary team. It states that the decision to even consider a high-risk PCI absolutely must involve a formal team discussion. It's not optional.
The heart team mandate, as they call it. And this isn't just a casual chat, right?
Oh, definitely not. It requires formal input from the interventional cardiologists who might do the PCI, the cardiac surgeons who ruled out CIBG, and ascites who understand the hemodynamic risks involved, and crucially, the heart failure specialists, the non-invasive doctors managing the underlying condition. They all need to come together, look at the whole picture, and agree on the best path forward, or indeed whether any invasive path is appropriate.
So when they meet, what are the key things they're looking for to say, okay, yes, this incredibly high-risk PCI might be worth it? What justifies taking that risk?
It really boils down to three main conditions being met. First, surgery, CIBG, has to be definitively off the table. Either the surgical risk is deemed prohibitive, maybe severe lung disease, kidney failure, extreme frailty, or the patient, fully informed, has refused it.
Okay, so surgery's out. What's next?
Second, the best possible medical treatment, what we call optimal medical therapy, or OMT, must have already been tried and shown to be insufficient. The patient still needs to have significant limiting symptoms like severe chest pain, angina, or repeated hospital stays for heart failure, despite being on all the right medications.
So medical therapy isn't enough on its own.
Correct. And third, perhaps the most critical piece. The team has to believe that doing the PCI, opening up those blockages, is likely to offer a prognostic benefit, meaning it's expected to improve the patient's outlook, not just temporarily relieve symptoms.
Can you paint a picture of the kind of artery blockages that would suggest a real prognostic benefit in someone this sick?
Yeah, we're talking about really critical situations. Things like severe disease in the left main coronary artery, that's the big one supplying most of the heart muscle, or blockages in the last remaining open vessel supplying the heart. Also, having chronic total occlusions, CTOs, these completely blocked arteries that supply large areas of heart muscle that are still alive but starved for blood, fixing those can make a big difference. Or just really widespread disease across all three major coronary arteries, especially if there's proof of large areas of ischemia, meaning muscle at risk.
So it's about identifying situations where restoring blood flow could potentially save heart muscle or prevent a catastrophic event.
Exactly. But the heart team also has a duty to consider the downside, including the very real possibility of futility.
Futility meaning the procedure might technically work, but the patient won't actually benefit overall.
Precisely. If the chances of successfully opening the blockages are very low, technically difficult, or if the patient has other overwhelming health problems like advanced cancer or end-stage lung disease that severely limit their life expectancy anyway, then putting them through a high-risk PCI might be considered futile. In those cases, the consensus guides the team towards focusing purely on palliative care, optimizing medical therapy for comfort, rather than pursuing an invasive procedure with little chance of meaningful long-term gain.
That naturally leads us into the evidence, or maybe the lack of really strong evidence, for this specific group. Given how fragile these patients are, it must be hard to do big clinical trials.
What's fascinating here is, well, just that. There's a real lack of definitive randomized controlled trial, or RCT, data that focuses specifically on this group, the ones turned down for surgery. We're often operating a space where the clinical need, the reality of these sick patients showing up, is way ahead of the research. So we end up referencing trials that studied less sick people.
Let's go back to SDCH. That's the big trial supporting surgery. Why doesn't it directly apply here again?
SDCH, and especially its long-term 10-year follow-up, was crucial. It showed that for patients with bad heart function, around 27–28% LVEF on average, having bypass surgery led to better survival over many years compared to just taking medications. That's why CIBG is the guideline standard. And it's a bid, but SDCH specifically picked patients who were considered low or medium risk for surgery. The patients we're talking about today, the ones considered for high-risk PCI, are by definition high or prohibitive surgical risk. You just can't assume the same survival benefit applies when you move from a relatively healthier surgical candidate to, say, a 90-year-old with kidney failure and severe frailty.
Okay, so surgery has data, but maybe not for the right patient profile.
Yep.
What about the PCI side? There was the big Revive PCIS2 trial recently looking at PCI plus meds versus just meds alone.
Yes, Revive PCIS2 was a significant trial. It took patients with low LVEF, 35% or less, who also had evidence of viable hibernating heart muscle that might recover with blood flow. The main finding, though, was neutral. Over about 41 months, adding PCI to optimal medical therapy didn't show a clear win over OMT alone when looking at the main goals, death or hospitalization for heart failure.
On the surface, that sounds pretty bad for PCI in this setting. But the consensus statement we're discussing still seems to carve out a role for PCI, despite Revived. How do they square that circle?
It comes down to really digging into who was in the Revive trial. While they had low LVEF, many weren't the super symptomatic end-of-the-line patients that typically get turned down for surgery and are the focus of this consensus.
So a different flavor of patient.
Kind of. Many patients in Revived had, relatively speaking, intermediate complexity blockages. And importantly, a lot of them weren't desperately symptomatic. Many were in what we call NYHA class 1 or 2, meaning minimal symptoms at rest or with mild exertion.
So maybe if you're relatively stable on meds, even with bad heart function, the added risk of PCI doesn't give you a big mortality benefit.
That could be the interpretation. If someone is stable, maybe aggressive intervention isn't needed. But the patients this consensus focuses on, they're typically highly symptomatic, NYHA class 3 or 4, often having failed medical therapy already. For them, PCI isn't just about long-term mortality, which Revived focused on. It's often about improving their quality of life right now, reducing debilitating angina, or constant shortness of breath. That's a goal Revived might not have fully captured.
Okay, so the consensus view seems to be OMT, optimal medical therapy, is absolutely fundamental, no question. But for those specific patients turned down for surgery who are really suffering despite meds and who have those critical blockages we discussed, then high-risk PCI becomes a sort of necessary alternative.
That sums it up well. It's seen as a viable option, supported by data from registries and observational studies, which often do include these sicker patients. This data suggests PCI is feasible, and with modern techniques like drug-eluting stents, DES, the long-term outcomes can be acceptable, especially if you achieve good revascularization.
So even without that perfect RCT evidence for this exact group, the consensus provides a framework for how to proceed carefully in this clinical gray zone where intervention feels necessary.
Exactly. It's about managing risk and aiming for the best possible outcome when the ideal option isn't available.
Let's dive into the procedure itself then. What makes doing PCI, the stenting, technically so much more dangerous in someone with a really weak heart, low LVEF?
The core issue is the almost complete lack of cardiac reserve. Think of it like an old car engine that's barely running any tiny disruption and it just stalls out completely.
So small problems become big problems very quickly.
Instantly. In a patient with a healthy heart, if you have a temporary issue during PCI, maybe the balloon inflation blocks flow for a minute or you get a small dissection, a tear in the artery lining the strong heart muscle can usually maintain blood pressure. But in someone with an LVEF under, say, 30%, that same brief interruption in blood flow can trigger immediate hemodynamic collapse. Their blood pressure plummets, they can go into shock, or even suffer a full cardiac arrest right there on the table. The heart just doesn't have the strength to compensate for even minor procedural setbacks.
Cardiologists often use scoring systems, like the syntax score, to gauge how complex the blockages are. Does the consensus think these scores are good enough for predicting risk in these low LVEF patients?
The consensus is pretty clear on this. No, they're not sufficient on their own. Scores like syntax are great for measuring the anatomical burden of disease, how much plaque, how many blockages, but they dramatically underestimate the actual physiological risk when you add severe LV dysfunction into the mix.
Why is that?
Well, consider the syntax score 2, which tried to incorporate clinical factors. When they developed that score, patients with low LVEF made up only about 2% of the entire group studied. So the score just isn't weighted properly to reflect how profoundly a weak heart changes the game. It fails to capture the true procedural danger in this specific population.
So if the scores aren't enough, the consensus seems to shift focus towards identifying specific anatomical patterns that just scream high risk in this context.
Precisely. Instead of relying on a potentially misleading score, they highlight pragmatic, real-world scenarios that demand the utmost caution, skill, and support.
What are those key patterns?
We touched on them before. Doing PCI on the patient's last remaining open coronary artery, any intervention on the left main artery, tackling complex, diffuse three-vessel disease that requires multiple stents and advanced techniques, and dealing with chronic total occlusions, CTOs, especially if they supply a large territory. These situations inherently carry much higher risk in a low LVEF patient, and this leads directly to a really crucial point in the consensus. These high-risk procedures should only be performed by highly experienced operators, people who do complex PCI routinely day in and day out and have a high volume.
This isn't the place for learning on the job, basically.
Absolutely not. You need operators who have seen complications, know how to anticipate them, and can manage them immediately and effectively. It requires a specific skill set and a cool head under pressure.
To improve the odds of success in these tricky cases, the consensus really pushes for using intracoronary imaging, doesn't it? Things like IVUS and OCT.
Yes, it's strongly advocated. It's moving rapidly from just being best practice towards being considered a necessary standard for complex, high-risk PCI.
Why is seeing inside the artery so critical here?
Intravascular ultrasound, IVUS, and optical coherence tomography, OCT, give the operator an incredibly detailed real-time view from inside the coronary artery. You can precisely assess the plaque characteristics. Is it soft, fatty, or hard calcified? You can measure the true vessel size much more accurately than with angiography alone. And crucially, after placing a stent, you can use imaging to ensure it's perfectly optimized, fully expanded, pressed firmly against the vessel wall with no edge problems. This optimization step is proven to significantly reduce the risk of later complications like stent thrombosis or restenosis.
But there's always a trade-off, isn't there? Using IVUS or OCT takes extra time, uses more contrast dye,
Yeah.
both potentially bad for these fragile patients.
That's the constant tightrope walk for the operator. Every extra minute the procedure takes is more ischemic time for the already struggling heart muscle. And these patients often have pre-existing kidney problems, partly due to their heart failure.
Right, the cardiorenal connection.
Exactly. So every additional milliliter of contrast dye increases their risk of contrast-induced acute kidney injury, which itself is a major negative predictor of long-term survival. So the operator has to constantly weigh the benefit of getting that perfect, image-guided technical result against the risks of prolonged procedure time and contrast load. However, the consensus ultimately comes down on the side of using imaging.
Why?
Because the evidence suggests that the reduction in major adverse cardiac events, heart attacks, stent failures, repeat procedures achieved through optimized stenting generally outweighs the temporary procedural risks in this specific high-stakes setting where getting it right the first time is paramount.
This focus on getting it right leads us to the concept of completeness of revascularization, or CR. We know intuitively that fixing all the major blockages should be better.
It's more than intuitive. The data is pretty strong. Achieving CR is consistently linked to better long-term survival, fewer major adverse cardiac events, MAC, and also, importantly, a better quality of life for the patient. Leaving significant blockages behind what results in a high residual syntax score clearly predicts worse outcomes.
But the consensus makes a really interesting distinction here about what kind of CR we should aim for in high-risk PCI compared to surgery. Here's where it gets really interesting. When a surgeon does CABE, the goal is typically anatomical complete revascularization, right? Bypass every significant narrowing they see.
That's generally the standard surgical approach, yes. Aim for anatomical perfection.
But for high-risk PCI in these fragile patients, the consensus advocates for something different.
Yes, and this is a key philosophical shift outlined in the document. For high-risk PCI, the heart team should prioritize achieving functional complete revascularization.
Okay, break that down. What's the practical difference between anatomical CR and functional CR?
Think of it like this. Anatomical CR is trying to make the angiogram look perfect. Fix every single spot that looks narrowed, maybe even lesions that are only 50% or 60% blocked, but might not actually be causing significant flow limitation. Functional CR, on the other hand, is more targeted and pragmatic, especially in high-risk settings. It means focusing on treating all the blockages that are clearly hemodynamically significant, the ones proven to be restricting blood flow, either through physiological testing or because they are clearly culprit lesions responsible for the patient's symptoms or large areas of ischemia.
So you fix the blockages that are actually causing the problem.
Essentially, yes. If, after fixing the main culprits, maybe the left main, a critical LAD blockage, and a tight right coronary lesion, there's another blockage in a smaller vessel, maybe a complex bifurcation that looks 60% narrowed but isn't causing major ischemia, the heart team might decide that the added risk of tackling that lesion outweighs the potential benefit.
So it's about risk-benefit for each individual lesion, not just making the pictures look clean.
Exactly. Functional CR is about achieving the maximum clinical benefit with the minimum procedural risk. Spending an extra hour using more contrast, risking instability to fix a lesion that's anatomically present but functionally less important, that might actually increase the patient's overall risk of dying on the table or having a major complication. It's about knowing when to stop, prioritizing safe, effective treatment of the critical lesions over achieving anatomical perfection at potentially devastating cost.
That sounds like it requires incredible judgment, especially when you throw something like a chronic total occlusion, a CTO, into the mix.
CTOs represent the pinnacle of PCI complexity. They are, by definition, 100% blocked arteries, usually for a long time. Trying to open them is technically demanding, takes a long time, uses a lot of contrast and radiation, and carries a higher risk of complications like perforation.
So what does the consensus say about tackling CTOs as part of functional CR?
If a CTO supplies a large area of viable heart muscle and is considered essential for achieving adequate functional revascularization, the consensus is very clear. A dedicated, experienced CTO operator must be involved. Either they perform the procedure themselves or they are readily available to consult and assist.
It's a subspecialty within interventional cardiology.
Absolutely. CTO PCI requires specific wires, catheters, techniques, and a different mindset. The consensus stresses that if you're going to attempt a high-risk CTO in a low LVEF patient, you need that specialized expertise, and you likely need the hemodynamic stability provided by mechanical support to even attempt it safely and effectively achieve that functional CR goal.
That's the perfect segue into mechanical circulatory support, or MCS, the high-tech safety net. What are the main types of support we're talking about here?
MCS devices are essentially temporary heart pumps used during the procedure to help maintain blood pressure and organ perfusion when the patient's own heart is too weak to cope with the stress of the intervention. The consensus focuses on three main categories.
Okay, what are they?
First, there's the intra-aortic balloon pump, the IABP. It's the oldest, simplest, and least invasive form of support. Second, you have the microaxial flow pumps. The most common example is the Impella family of devices. These are more powerful pumps placed across the aortic valve. And third, there's venorarterial extracorporeal membrane oxygenation, or VA-ECMO. This is basically a temporary external heart-lung bypass machine, providing the highest level of support but also being the most invasive.
In what kind of PCI situations would the team consider using one of these devices prophylactically, sort of putting it in beforehand?
Typically, they're considered for the absolute highest risk procedures. Things like intervening on a critical, unprotected left main stenosis where even a brief blockage could be catastrophic, or during complex lesion preparation techniques like rotational atherectomy, where you're essentially drilling through heavily calcified plaque, or intravascular lithotripsy, using shock waves to break up calcium. These techniques can sometimes cause temporary slow blood flow or debris showering downstream.
So anytime you anticipate a high likelihood of the patient becoming unstable during the procedure.
Exactly. Or simply if the planned procedure is expected to be very long and complex in a patient with severely depressed heart function. It's about providing a safety margin, keeping the patient stable so the operator can focus on fixing the arteries effectively.
Let's quickly touch on the limitations of each type. The IABP.
The IABP helps by inflating in the aorta during the heart's resting phase, diastole, and deflating just before contraction, systole. This reduces the workload on the heart slightly and can improve blood flow to the coronaries themselves. But crucially, it relies on the patient's heart still generating some effective forward blood flow.
So if the heart really tanks,
the IABP becomes much less effective. It doesn't work well with very fast heart rates or arrhythmias. And if the patient goes into actual circulatory arrest, it provides very little meaningful support. It's best suited for milder hemodynamic instability.
Okay, what about the microaxial pumps, like Impella? They actively pump blood, right?
Correct. They sit across the aortic valve, actively pulling blood from the left ventricle and ejecting it into the aorta. Depending on the device size, they can provide significant, consistent forward flow up to 5 liters per minute with the larger devices. This directly unloads the struggling left ventricle, reducing its workload and oxygen demand, which is very beneficial.
Any downsides?
The main limitation is they need adequate filling of the left ventricle, what we call preload. If the patient becomes very volume depleted, or if the right side of the heart fails and can't deliver blood to the left, the pump can suck down the ventricle walls, causing alarms and potential injury.
And VA ECMO, the most powerful option.
VA ECMO provides full cardiopulmonary support. It drains deoxygenated blood from the venous system, runs it through an external oxygenator, and pumps oxygenated blood back into the arterial system, completely bypassing the patient's heart and lungs.
Sounds ideal for the sickest patients.
It provides the most robust support, yes, but it's highly invasive, requiring large cannulas in major vessels. And importantly, by pumping blood directly back into the arterial system, it significantly increases the pressure the native left ventricle has to pump against. This is called increased LV afterload.
Which could be bad for an already failing heart.
It can be. The weak LV might struggle to eject blood against this high pressure, potentially leading to backup of blood in the lungs, pulmonary congestion, or even preventing the aortic valve from opening properly. This is why, for many high-risk PCI scenarios where the lungs are still okay, the consensus tends to favor microaxial pumps. They offer a good balance of adequate hemodynamic support while directly unloading the LV and are less invasive than ECMO.
Given that these devices clearly help keep patients stable during tough procedures, you'd think the clinical trial data would overwhelmingly support using them routinely. But it sounds like the evidence is actually quite controversial.
It is surprisingly complex and, frankly, somewhat disappointing given the intuitive appeal of hemodynamic support. Let's start with the IABP and the BCIS-1 trial. BCIS-1 looked at routine IABP use versus no plan IABP in patients with LVEF less than 30% undergoing complex PCI. The primary result, looking at major complications at discharge, was negative. Routine IABP didn't seem to help in the short term.
But that wasn't the end of the story, was it?
No. Years later, they published a long-term follow-up, and somewhat unexpectedly, they found a statistically significant 33% reduction in all-cause mortality at around 4 years in the group that originally got the routine IABP.
Wow. So no short-term benefit, but maybe a long-term survival advantage.
That's the hypothesis. It's purely exploratory, not the trial's main goal, but it suggests that maybe the temporary support provided by the IABP, even if it didn't prevent immediate procedural issues, might have offered some kind of longer-term myocardial protection or allowed for better recovery. It's this finding that keeps the debate alive.
And what about the trials for the more powerful microaxial pumps, like PROTECT 2 comparing Impella to IABP?
PROTECT 2 also had ambiguous results. The trial was actually stopped early because they calculated it was unlikely to show a significant difference in the primary endpoint, a composite of major adverse events at 30 days. So officially, Impella failed to prove superiority over the IABP for that short-term goal.
But were there any hints of benefit?
Again, in secondary or exploratory analyses, yes. There were suggestions that the Impella group might have had slightly better LVEF recovery at 90 days and potentially lower rates of acute kidney injury compared to the IABP group. But these weren't the main findings. So the bottom line from the major trials is, while MCS clearly makes complex procedures feasible and keeps patients stable during the PCI, the current evidence doesn't definitively prove that using it routinely leads to better heart outcomes, like reduced mortality or fewer heart attacks compared to doing the procedure very carefully without plan support.
So with this murky trial data, what's the final verdict from the consensus statement on using MCS? Should operators be putting these devices in everyone undergoing high-risk PCI?
The consensus is quite clear and cautious on this point. MCS should not be the default automatic strategy for every single high-risk PCI procedure.
Why not, if it provides stability?
Because the definite risks associated with MCS are well established, while the benefits in terms of long-term morbidity and mortality remain unproven in large RCTs. You have the increased risk of vascular complications from the large arterial access required, a higher risk of bleeding, often requiring transfusions, which have their own risks, and potentially more contrast exposure during insertion and positioning.
So it really comes down to a careful, individualized risk-benefit calculation for each patient.
Absolutely. The heart team needs to weigh. Is the planned revascularization strategy so complex or the patient so unstable that the hemodynamic stability provided by MCS is deemed essential to even attempt the procedure safely and achieve the desired functional CR? If yes, then the benefits might outweigh the risks. But if the procedure, while high risk, seems achievable without support by an expert operator, then the added risks of MCS might not be justified. It's very much a case-by-case decision.
Is there hope for clearer answers soon?
Yes, thankfully. There's a large ongoing trial called PROTECT 4. It's randomizing over 1,200 patients with LVEF 40% or less undergoing complex PCI to either receive planned Impella support or proceed without planned support, though bailout IABP is allowed. This trial is specifically designed to answer the question of whether routine prophylactic use of microaxial pumps improves major outcomes. Its results are eagerly awaited.
Until then, it's careful selection. And if MCS is used, managing the access site seems critical, given the risks you mentioned.
Vascular complications are arguably the Achilles heel of MCS. These large sheaths, often 10 French, 14 French, or even larger for ECMO, can cause serious damage to the femoral artery dissection, perforation, major bleeding, limb ischemia.
So what does the consensus say about preventing these problems?
Meticulous pre-procedural planning is non-negotiable. You can't just rely on a quick bedside ultrasound. The consensus strongly recommends getting better imaging of the access vessels beforehand, usually with a CT scan or sometimes invasive angiography during the heart cath.
What are they looking for?
They need to accurately measure the vessel diameter. Is it big enough? Typically needing to be over 5 millimeters, ideally larger, to safely accommodate the sheath without tearing. Is there severe calcification or tortuosity that would make insertion difficult or dangerous? This planning avoids trying to force a large sheath into an inadequate vessel, and then managing the hole after the device comes out is just as important. For these large bore access sites, the consensus favors using pre-closure devices. These are typically suture-based systems deployed before the main sheath goes in, allowing for a more controlled and reliable closure afterwards compared to just holding manual pressure for a long time.
What about devices used after the fact?
Post-closure devices like plugs are available, but some data, for instance from the choice closure trial in TAVR patients, who also get large sheaths, suggested potentially higher complication rates with some post-closure strategies compared to suture-based pre-closure. So the emphasis remains on careful upfront planning and meticulous technique, usually favoring pre-closure, followed by vigilant monitoring for any bleeding or vascular issues.
Okay, let's assume the team navigates all this. The high-risk PCI is technically successful, the patient is stable, maybe with or without MCS. The consensus makes it clear the job isn't done yet. Post-procedural care is vital.
Absolutely critical. Getting the patient through the procedure is only half the battle. Optimal medical therapy, OMT, isn't just something you try before PCI. It's the absolute cornerstone of long-term success after PCI.
The consensus really hammers this home.
It does. It states very firmly that guideline-directed medical therapy for heart failure must be initiated or optimized aggressively, ideally even before discharge after the PCI.
So making sure they're on that full cocktail of heart failure medications.
Exactly. Assuming there are no contraindications, this means pushing towards target doses of the 4 pillars of modern HF therapy. Usually an ACE inhibitor or ARB or ARNA, a beta blocker proven for HF, a mineral corticoid receptor antagonist or MRA like spironolactone, and one of the SGLT2 inhibitors, which have shown remarkable benefits. The consensus stresses that getting patients on these drugs, titrating them up effectively, and ensuring adherence is absolutely paramount for promoting any potential myocardial recovery, controlling symptoms, and improving their long-term survival after the revascularization.
And the follow-up plan needs to be different for these patients too, right? They can't just be treated like a standard PCI patient.
Definitely not. The reality is that heart failure itself remains the single biggest reason these patients end up back in the hospital after their high-risk PCI. They are systemically fragile.
It's not just their heart.
No. They frequently have significant coexisting problems: chronic lung disease, moderate to severe kidney disease, sometimes liver issues. All of these complicate their recovery and management, so they require specialized, dedicated long-term follow-up, ideally within a structured heart failure program. They also need access to adapted cardiac rehabilitation programs that understand their severe deconditioning and multiple comorbidities. Standard rehab might be too much for them initially.
Finally, let's talk about the place where these procedures happen. The consensus is pretty strict about the kind of institutional setup required, isn't it? This isn't something just any hospital cath lab can or should be doing.
That's right. Performing these procedures safely and effectively places huge demands not just on the operator, but on the entire institution. The consensus lays out some non-negotiable logistical and personnel requirements.
What are some key institutional checks that need to be in place?
Well, before even thinking about the procedure, the basics must be covered. Proper informed consent is huge, ensuring the patient and family truly understand the very high risks, including death or stroke, balanced against the potential benefits, which might primarily be symptom relief rather than guaranteed longer life. Offering a second opinion is also considered essential. Kidney function must be formally assessed and documented because of the contrast risk. And critically, there must be guaranteed immediate availability of an intensive care unit bed post-procedure. You simply cannot risk performing such a high-risk case without knowing you have the ICU backup ready if the patient needs prolonged monitoring or extended MCS support. That bed should ideally be pre-booked. And then there's the operator and team expertise. The skill level required is substantial.
What specific skills does the consensus highlight?
Operators need documented experience and proficiency in advanced access management, not just routine radial access, but also safe, large-bore femoral access for sheaths 10 French or larger. They must be comfortable with advanced techniques for dealing with complex calcified lesions, things like rotational atherectomy and intravascular lithotripsy. Proficiency with intracoronary imaging, IV Cru SOCT, and coronary physiology measurements is expected. And crucially, they need the skills for immediate bailout interventions, most notably rescue pericardiocentesis, being able to rapidly drain fluid from around the heart if a perforation occurs. That's a potentially life-saving skill in this context. The entire cath lab team, including nurses and techs, also needs specific training and familiarity with setting up and managing the various MCS devices.
So what does this all mean? Well, it seems this consensus statement really acts as a vital roadmap. It's guiding clinicians on how to manage this rapidly growing, incredibly challenging group of of patients, those with severe heart failure who are just too sick for bypass surgery. It formalizes that crucial multidisciplinary heart team approach. And procedurally, the focus is clearly on achieving functional complete revascularization, fixing the problems causing the ischemia while using mechanical circulatory support, especially those microaxial pumps, judiciously. Not routinely, but as a carefully considered tool to enable safe completion of the PCI when stability is paramount.
Precisely. It provides a much-needed structure for decision-making in an area where, as we've discussed, the top-level randomized trial evidence for this specific population is still lacking or controversial. But while providing this framework, the document also implicitly highlights the major gaps in our knowledge, the things we still need to figure out.
What are the big unanswered questions that clinicians doing this work still grapple with?
There are several key ones. First, believe it or not, we still don't have a really precise handle on the true size of the specific patient population, how many people truly fall into this high-risk surgical turn-down category across different healthcare systems. Second, and this is probably the most fundamental question, does performing these complex, extensive revascularization procedures actually improve long-term mortality or genuinely provide sustained quality of life benefits in this particular cohort? We hope so. We often act as if it does, but the definitive proof is still elusive. And third, regarding the support devices themselves. Are the different types of MCS truly equivalent in terms of cardioprotection and outcomes? Or does one type, say, microaxial pumps versus IABP or ECMO, offer a distinct advantage or a better safety profile in this specific setting? We still need better comparative data.
That really underscores that the future probably lies in moving beyond these big, broad trials towards something much more personalized. So, the final provocative thought for you, the listener, to mull over is this. Perhaps the most critical challenge ahead isn't just refining techniques, but developing far more sophisticated predictive risk scores. We need tools that go way beyond just simple anatomy and LVEF. Tools that can accurately pinpoint which individual patient, currently deemed too sick for surgery, is most likely to derive a truly meaningful, life-altering benefit from undergoing an aggressive, high-risk PCI strategy. Only then can we provide a truly compelling, evidence-based rationale to justify undertaking these significant procedural risks. Thank you for watching The Funnel Effect.